Good afternoon. I'm very happy to be here to stay with you about the preliminary our study. The Vietnam is located in Southeast Asia, and we have a concentrated HIV epidemic and primarily driven by injection drugs. There's estimated 250,000 people living with AIDS, and so far we have more than 95,000 people on ART. And modeling study using the local data scattered that annually voluntary testing and immediate ART for the leads to significant reduction in new HIV infection and AIDS deaths, especially if access by in people who inject drugs is priorities. However, in reality in Vietnam, many PWIDs continue to start ART late with low CD4 counts. This is leading to limited clinical and preventive the benefit of ART. In this context, we designed a study as a demonstration project to assess operational feasibility and the acceptability of periodic voluntary HIV testing among PWID and immediate ART for the positive regardless CD4 counts. This study aims to facilitate earlier HIV diagnostic and earlier treatment initiation among PWID. The key outcome indicators of our study includes: the first is the viral suppression at 12 months after ART start. The second is retention across the care cascade. The third is level of risk behaviors. And we also doing the quantitative interview to assess feasibility and accessibility of intervention. Although this is not in the course of my presentation today. Our study is ongoing, and I hope that today we just focus about the interim results. For study methods, our study is one-armed intervention study, started at April 2014 in two provinces in Vietnam, Thái Nguyên and Thanh Hóa. And in the study provinces, HIV testing were recommended to PWID every 6 months. And once diagnostic HIV positive, PWID are provided with immediate ART, regardless of CD4 counts. Together with counseling to promote other prevention measures, following the consent form about benefit and the risk of earlier initiation of ART. We expected to have 300 people WID with HIV positive to start ART in our study. The PWID is defined as some criteria following. The first is those who self-reported inject drug within 30 days, or those who self-reported ever injecting drugs and had a visible injection site, or those receiving methadone maintenance therapy. It the study possible to follow up by 12 months, and they also receive HIV viral test before ARV start and after 6 and 12 month ARTs. And they also receive to monitor behaviors before ARV start and at 3, 6, and 12 months. Now, I would like to stay with you about the result of our interim analysis, which included 167 individuals who started ART by November of 2014. In this slide, show about their baseline characteristics. When we started this study in Vietnam, we applied the starting ART at or below CD4 counts 350 cells among adults. Although included in this study, we have 103 people with PWID started ART with CD4 count equal or less than 350, and 64 started with CD4 count over 350. And 99% of study participants was male, and the median age was 36 years and have 83% of the secondary education or higher. The median CD4 count and viral load at baseline was 257 and 63,000 respectively. And now I would like to talking about the retention. In overall, study participants show retention higher than 90% of them at month 6. Among those starting ART at CD4 count over 350, there was no attrition, and while there was 8 deaths and 1 loss to follow-up among those starting ART at CD4 less than 350. And for viral suppression at 6 months, the study participants also achieved high level of viral suppression at 6 months, regardless of CD4 count at the beginning of ARTs. The viral suppression was defined as viral less than 1,000 copies. Now, we would like to put the slide, we would like to put the retention and viral suppression in 6 months in one slide. This graph suggested that those starting ART and CD4 count over 300 still at achievement at least compare a level of retention and viral suppression compared with those starting with CD4 below 350. We follow the current national guideline. And before we started this study, that there was many concern about if we providing earlier treatment for people living with AIDS with the strong healthy, so maybe their adherence not so good. And however, with our study, this may be suggested that their adherence is rather good. We also monitor risk behavior of our study participants, which are still reported through interviewer, quantitative interviewer. The behavior was assessed because there was some concern about that people may be engaged or in more high-risk behavior. And however, if you can see that in this presentation, you can see that both behavior, clean litter use or consistent condom use very high, and no increase in high-risk behavior after in the first 6 months. In summary, we found that there are some limitations in my presentation because sample size is still very small, and the time for follow-up still after 6 months only. And however, our presentation results suggested some following here. The first is in our cohort HIV positive PWID in T.T.V in Vietnam, relatively the high level of detention, over 95%, and viral suppression, over 85% was observed, regardless of CD4 count at the beginning of ART. And the second is the self-reported circuit that no increase in litter sharing or unprotected sex after ART initiation. The third, this result suggested that the study intervention is likely feasible in Vietnam, and it is very useful for us when we release the new guideline HIV treatment in Vietnam. Now we are doing the analysis of the data, and I hope that maybe in the future when we finish this project, we will have a full take and have we'll talk about another of the TTT. In concluding of my presentation, I would like to take acknowledgement to Dr. Marcel Carto, who are working in WHO in Vietnam, and all the investigators in this study, as well as the study participants, healthcare workers at study site, and community collaborators and peer readers and donors. Thank you very much for your attention.
Okay, so questions, comments?
Sure.
We'll start on this side first.
Hi, I'm Julie. I'm a nurse here in Vancouver. I was just wondering, I think you said that 99% of the participants were male.
Yes?
I'm just wondering, where that number comes from, or why women weren't more robustly recruited?
Sorry?
I was just wondering why there weren't more women recruited for the study,
Oh.
or if there was a particular reason for that.
Oh yes, but actually in Vietnam, the most of the IDU in Vietnam is the male. It's in the general situation in Vietnam. So in our studies, they reflected that the 99% the male is male. It's a suitable with the general situation in Vietnam. Yeah, thank you.
Okay, next question.
Thank you very much. Thank you very much for your presentation. Can you talk a little bit more about the recruitment methods for bringing people into the study and the percentage that were on methadone, for example? You said that that was an eligibility criteria as well. And in terms of the loss to follow-up, were there any specific efforts undertaken in order to protect people from detention in compulsory drug detention centers or treatment centers?
Could you please slowly?
Sure.
Question?
So 2 questions. The first,
Yes.
can you say more about the recruitment of participants in the study? What percentage were on methadone, for example, where and how you got them into the study?
Yeah. So actually, when we have this data and have in my presentation, we still, as I mentioned, because the still ongoing. That is why so far we have no data about this. But I want to say with you that the ATC, I mean when we providing HIV testing, we do in the methadone side and also in the PIDC in the ATC side. And many people in IDU in our study they are on methadone, but we have data in my presentation because our study is ongoing.
Okay. And then the second question was just, were there any efforts made to protect people from being detained by the police or being put in the 06 centers for compulsory drug treatment?
I'm sorry.
So your results were very high in terms of retention and
Yeah.
very low in terms of loss to
Yeah.
follow-up.
Yeah.
You would expect that some
Okay.
participants
I-
would have conflict with the law.
Okay, so in our study, we based on about the community. We have we based on the network of peer educator, IDU, and also village healthcare worker. And before we develop this proposal, we meet about the healthcare worker, peer educator, and IDU. So we talk with them about our protocol, and we talk to them about we want to support the adherence for the patient. Actually, all our peer educator, health worker, they approach with the IDU and providing HIV counseling, providing about the benefit of ART, benefit of HIV testing. And after that, they support the patient go to the OPC, link it to care. And they also all ongoing to support adherence for this patient. I mean, our studies, we based on the peer educator, communities health worker, and they support for adherence for the IDUs, our participants.
Thank you.
Thank you.
I just had a really quick question. I just wanted to clarify what kind of HIV test was administered, because I wanted to understand what window period we were looking at here in those discoveries of infections. So were they tested, were they tested for RNA? Were they tested?
Okay. So actually, we did the HIV testing in the HIV testing, in the VCT side, and also in the community health station. In some time, we have to move, the mobile ATC, mobile counseling testing. We have to go to the house of peer educator and providing HIV testing in their home.
But I actually meant what testing protocol was utilized in order to identify HIV positive.
We using the national guideline. Actually, at the beginning, we using the rapid test.
Okay.
Yeah.
Thank you.
So in confirmation, we have to send to the convalescent labor center.
Hi. You said that during your study, 8 people were dead. Do you know the causes of the death? Was it overdoses or because of the HIV or something else?
Could you repeat the
Oh,
question?
sorry. You said that during the study, 8 people were
Yeah.
found dead.
Yeah.
So what are the reasons, the causes of these deaths?
Oh, yes. So, for the AIDS deaths, we have 2 cases, the death not by AIDS, death by the using the drug. And for AIDS, for 6 AIDS by because they go to the access with the can treatment too late. So in that situation, they die by the under a while, yeah, because they go to come late. Yeah.
Thank you, Dr. Nunn. It's a really lovely example of, I guess, implementation science and gathering local evidence, which is really important for policy change in that context.
Yeah.
It's really useful research.
Sure.
Thank you.
Very useful for us. Actually, we in Vietnam, after we doing this study, we apply the tech and treat in some mountain provinces by the January of this year, and by the May of this year, we issue the tech and treat for all the key population, ideal sex worker and MSN2. And now this apply in whole country. Thank you.
So this means that people who inject drugs have access to immediate ART. They're a priority population in Vietnam now. It's a great result.
Yeah, thank you.